All right. So thank you to everyone that has joined today. I think some of you might have already attended the brain awareness events this week, but in case you haven't, I'm Margaux, and I'm the group lead for the special interest group on eating disorders. And I'm a postgraduate student on the Applied Neuroscience program at King's and a member at Anna. I just wanted to highlight here a couple of other talks that are happening this week. So two have already happened, but there's still two really exciting talks coming in the next couple days. So definitely check those out. And the link to Anna is on the Eventbrite page. So I definitely recommend checking that out. So yeah, without further ado, I will just launch right in. All right. So today I'm going to be talking about the neuroscience behind eating disorders, focusing specifically on why these conditions develop, why they can be so persistent, and how neuroscience is helping to guide us toward more effective treatments. So a bit of a general overview, but to keep things cohesive and have a clearer narrative, I'm going to focus in on anorexia. The clinical name is anorexia nervosa. That is really my specialty in terms of the research that I'm doing. It's not the most common eating disorder. Bulimia nervosa and binge eating disorder are both more prevalent than anorexia, but anorexia is the most fatal eating disorder, also the most fatal psychiatric disorder with a mortality rate higher than any other mental health condition. So it's definitely an important area to research in terms of looking for interventions. One thing that I'm just really excited about right now is all of the developments that are happening in various neuroscientific research pursuits to really uncover what anorexia is and what's happening in the brain, because that offers a lot of promise toward developing better treatments. So I've just included this figure on the left, which hopefully you can see, but it's kind of a nice little demonstration of how anorexia is a combination of psychiatric symptoms and everything that's happening mentally and cognitively, but it's also just particularly challenging to treat because it's also a combination of behaviors related to food and eating and different metabolic traits. So you have a lot of physical symptoms that play in, as well as just different physical changes that are throughout the rest of the body and in the brain. So let's take it to the anorexia and the sort of the combination of psychological and biological factors. So as I just covered off, anorexia, like most eating disorders, is incredibly complex. And one area that's become an area of interest in research more recently is looking at the intersection of the gut-brain axis. And the gut-brain axis refers to a two-way communication that happens between the gut and the brain. So this research is showing that disruptions in the gut microbiota, which is the community of organisms that are in our digestive system, can influence our brain function and our behavior. So in anorexia, we have this gut dysbiosis, this imbalance of bacteria, which can contribute to symptoms of anxiety and depression, which are both not only common comorbidities in anorexia, but also a part of the emotional experience, as well as influencing decision making, which is quite an interesting one for anorexia, where we see an intentional restriction of food and a refusal to eat. I don't know if I love the word refusal, but what seems like a choice. So this understanding how imbalances in the gut may influence our own decision making helps us understand a little bit better how we might make certain decisions about eating and how that can be disrupted in the disorder. So I'm going to break that down a little bit more to make it a bit clearer. So looking at the gut-brain axis, we can look through several different pathways. I'm going to outline three major areas. So if we look at the vagus nerve, this gives us the highway for connecting in the brain. So we get signals that are being sent both upward from the gut and downward from the brain. And then we've got the gut microbiota, where we have trillions of bacteria in our gut that produce neurotransmitters like serotonin and dopamine. And this impacts appetite. It also impacts mood. So it's something that where we can see disruptions in eating disorders like anorexia, but more recently, there's also a lot of evidence pointing toward the role of the gut-brain axis in a wide range of psychiatric disorders. So you might have seen research about that in depression, anxiety, in any range. I'm not as much of an expert on that research, but I know there's a lot going on for many different contexts. And then, yeah, the last part of this axis that I wanted to highlight is just immune and hormonal pathways. So this can be a very broad range. Like one hormone that will be implicated is looking at cortisol, which you might know is associated with stress and anxiety. So that's where we might get a certain fear response or fight or flight response, where individuals who have anorexia might have an extreme fear response when thinking about things like weight gain, or when thinking about specific fear foods, or just the context of eating. And these responses will be impacted by our cortisol levels, which are deeply interwoven into this whole system communicating between the gut and the brain. So how do we even know that this is happening? So one way that we're able to research the gut-brain axis is to look at animal models. I know that animal models might not be something that everybody loves, or that they can be a bit controversial in terms of how well we're able to represent the disorder. But the activity-based anorexia rodent model provides a really interesting model for understanding anorexia. And the reason that it's so interesting and so relevant is that it's the only animal model in scientific research where we actually see animals intentionally choosing self-starvation behaviors. So within the experimental conditions, without genetic manipulation or without any manipulation beyond the environment that we put these rodents in, we see a choice for the rodents, because it's done both in mice and rats, or it has been done in both, to choose over exercise and restrict their own eating behaviors to the point of starvation unless we intervene. So that's just a bit on activity-based anorexia, because it's something that I find quite interesting. So looking at the activity-based anorexia model, there's a body of evidence where researchers have observed changes in gut bacteria that have mirrored those seen in humans with anorexia. So that's giving us a way to validate that some of this research has a certain translational potential, meaning that what we study in animals will help us inform what we understand in the human body. And when intervening with probiotic treatments, prebiotics, or specific dietary interventions, including focuses on like a ketogenic diet, that's one option that has been explored. Research has shown this restoration of the gut microbiome. So what we can see in animal models is that not only does the behavior improve in terms of overexercising and self-starvation, but when we look at what's actually happening in the gut, things are going back to a much more normalized profile. So this offers some promising new directions for looking at how we might be able to include dietary supplements or specific supplements in the treatment of anorexia. And just highlighting a new potential treatment target, which I do want to stress would be something that could be a very useful adjunct to psychotherapy and potentially medication, but not necessarily something to use on its own. But since I've mentioned medication, I did want to highlight one point, which is that there are currently no approved medications or pharmacological treatments for anorexia. So while we can use certain medications that help with anxiety levels or might help with disrupted sleep levels, there's not a standard go-to for medication. And as we've sort of covered off earlier, we're dealing with like a very severe disorder that can often be fatal. So sort of any developments toward either a medication or a new intervention are very exciting because we're not really working from a framework of ineffective treatments. We're working from a framework of having very few approved treatments at all. So moving on from that, if we look at, okay, prebiotics, probiotics, dietary changes can be very helpful, and we're starting to see some of that used in practice. The standard go-to for treating anorexia, as with most eating disorders, is a form of cognitive behavioral therapy, or CBT. That's known as CBTE, so for eating disorders, and it is tailored to the context of eating disorders, applying a cognitive behavioral model, but targeting specific areas around fears of weight gain, fears of eating, questioning thoughts around that domain. And yet, even with pre-existing treatments, what we're seeing is that only 30% of anorexia patients actually show a complete recovery after treatment, which is usually investigated looking at follow-up after a certain period of time. So there might be like a 10-year follow-up, or some longitudinal studies might follow post either inpatient treatment or individuals who have undergone a specific therapy, looking at regular intervals after that treatment. And there's often sort of improvements noted, but there is a very small percentage of people who show a full recovery. So over the summer, I attended a conference held by a team of researchers at King's at the IOPBN, which looks at rapid intervention in eating disorders. So it was freed first response eating disorder engagement in eating disorders. So we're looking at how we can jump in and treat right away, because there's a lot of evidence to show the earlier we treat anorexia, the better our outcomes are, and the higher the chances for recovery. But I'm straying a bit from what's on this slide right now, because when we don't have either the opportunity for early intervention, or perhaps it's not diagnosed early enough, or it's just challenging to access care, one thing that we see is persistent eating disorders, which it's heartbreaking, but can often be labeled as treatment resistant. So individuals are seen as not able to recover, or despite treatment, it's believed that individuals might not get better. But I think the tides are really changing on that, in terms of shifting our mindset toward how we can better address a more persistent manifestation. So what I want to really zero in on here is looking at some of the cognitive processes that are happening in the brain at that time. So if we look from a cognitive side, we've got decision-making and emotion regulation that can be quite disrupted. And often the key circuits that are showing up are looking at reward processing and cognitive rigidity. So just to give a bit of context for, okay, what do I mean by that? Reward processing is something that's going to be, heavily involved in eating. We have hunger, we eat something, we might feel satiated or it might feel nice to eat. But when that becomes disrupted, there's not the same desire to eat always. It can vary from individual to individual, or there might not be that that feeling of experiencing the reward when eating despite hunger. And then when we look at cognitive rigidity, it's useful to look at a definition of cognitive flexibility, which I have some examples. So planning, reasoning, solving problems, multitasking. So those are all processes that allow us to switch how we're thinking in different ways. It's also really important for adapting behaviors. And so in the context of psychiatric disorders and in the context of eating disorders, that would involve adapting behaviors when our actions are harmful. So in eating disorders, we often see a low weight profile. That's not always the case, but we can have patients who are, or individuals, might not be in treatment, individuals who can have a very low body weight or very negative consequences on health, such as electrolyte imbalances or blood sugar levels that can drop, blood pressure levels that can drop. And what we see in eating disorders is this set of physical symptoms that are negative consequences on the body. So we might have frequent fainting. We can even see things like seizures, more rarely, more extreme heart attacks. So some very severe physical manifestations. And yet there's this inability to change behaviors, which might be around restricted eating, so restricting calorie intake, over-exercising to burn calories, or purging, which is often either in the form of taking laxatives or self-inducing vomiting. And there's this lack of a link where on one hand, there are all of these consequences from the behaviors, and yet it doesn't feel clear how to stop restricted behaviors despite experiencing all these consequences. So I just want to break down a little bit how we can understand these specific circuits and processes in the brain, because I know I'm leaving things a little bit vague looking at just cognitive flexibility and reward processing. So to give a bit more of a specific example, I want to highlight a key player here, which is something called brain-derived neurotrophic factor, or BDNF, which is going to be a much more simple way of referring to it here on in. So in neuroscientific terms, it's a growth factor that supports neuroplasticity. If that sounds like complete jargon to you, think of it as just a fertilizer in the brain, in a sense. So what we're seeing is that it helps neurons to grow and communicate effectively. So if we think of neuroplasticity as our ability to develop new connections, so perhaps like learning a new skill or starting a new habit, BDNF will play an important role in allowing for those changes to happen. So to get out of that cognitive rigidity and lean into a more flexible, like cognitive flexibility. And when we look at anorexia, what we can see is that BDNF levels are often disrupted. So it can be a bit challenging to get an accurate reading of BDNF in human populations, depending on the type of measurement. There are ways to look at BDNF levels, but we don't currently have the tools to zero in on seeing BDNF levels in specific circuits. So what I mean by that is we can understand the levels perhaps more globally in the brain, but it's very challenging to understand how a circuit that might be involved in reward processing or cognitive flexibility, how that circuit might be experiencing a disrupted BDNF level. Yes, also one thing I just thought I would highlight before moving on from this is the role of BDNF in emotion regulation. So for anyone who has been reading up on BDNF at all or hearing it in a podcast, I know there's a Huberman podcast all about it. It's very complicated and involved in circuits all over the brain. So it's quite challenging to disentangle what might be influenced, but we are seeing just in general, scientific research and eating disorder research is seeing impact in the specific circuits I've mentioned, as well as emotion regulation processes. So, okay, to describe how we might see that a little bit more clearly, okay, here is a bit of a jumbled looking diagram, but what you are looking at right now is a mouse brain. Now, all of the acronyms here that you're seeing in the diagram aren't super important. So if they mean something to you, that is a bonus. If they don't, no stress at all. I'm showing this diagram just because I wanted to contextualize this understanding within the animal model that we discussed earlier, looking at the gut-brain axis. So we've seen a certain body of research showing the validity of looking at animal models for understanding disruptions in the gut microbiome. But what might we see in the brain of a rodent who is engaging in anorectic-like behaviors, so self-starvation behaviors, over-exercise behaviors, and how might that inform what we can understand about actual human beings and about anorexia nervosa as a disorder, because obviously this is just representation, but no animal model can ever fully give us an accurate picture of a disorder because we're just mimicking certain symptoms, not the full thing. So in these ABA, the animal model we've been looking at, the activity-based anorexia, in these models, what researchers have been able to examine is lower levels of BDNF, which is the growth factor that we've been discussing, in certain key brain regions that allow us to understand the implications of disrupted BDNF levels with a bit more specificity. So the reason we need animal models here is that it wouldn't be ethical to conduct a study with this level of detail in humans, because often it will require sacrificing the animal at the end of the experiment to really look at everything under a microscope. But some of the acronyms I wanted to cover from this diagram are looking over here at the prefrontal cortex and also looking up here at the hippocampus. So this diagram is a little distilled down just to try to show how certain regions are involved in certain processes. Obviously, it's very complicated, but all of what we're seeing in here is different disrupted circuits in anorexia. So the green that we're seeing connecting from the prefrontal cortex to different areas, we're looking at that cognitive flexibility. So again, looking at changing behaviors or looking at something from a new perspective. And then the hippocampus up here in blue will really touch upon mood and memory. So for mood, we'll be looking at emotion regulation. And I mean, really mood, I don't think there's any psychiatric disorder that doesn't have mood as a key area that's being impacted. And then memory, which plays a very important role in reward processing in a sense, because we'll have a memory of a previous experience, which allows us to either proceed with wanting to repeat a behavior or interplaying with that cognitive flexibility in terms of remembering, having perhaps like a biased memory or going back to a certain pattern, or perhaps a memory that might influence our behavior, such as looking at like a negative past experience that might have been a shaming experience around weight or food or eating, and how that might then impact our behaviors moving forward. So how a shameful experience, like being a comment made about someone's weight, could remain an important factor that is influencing different decisions rather than being able to form different newer associations. So again, this is a little bit complicated, but what we're really just seeing is this really complex presentation of BDNF in the brain, where we've got some levels where it's very high, some levels where it's inhibited, where we're not seeing as much of it, and then some circuits where we're seeing levels that are mixed. So within the same circuit, it's a bit all over the place. Okay, so why does that matter? I've just given you a lot of detail. Really, the significance here is that certain treatments are thought to alter BDNF levels, and a key one is ketamine right now. So ketamine is currently being explored for depression and for chronic depression, persistent depression, treatment resistant, whatever terms you prefer. And BDNF plays an important role there, but where things get a bit tricky with anorexia is that there might be certain circuits where we want to have more excitation, we want more boost, certain we need more inhibition, we need to lower. So to really just spell that out, we've got over-exercise, where we have a behavior that's happening too much. There's something that we want to pull back on and slow down. But then we have restricted eating, where we want to boost eating and pull back on behaviors like extreme exercise. So ketamine is something that is currently being explored in eating disorders as well, because it's thought to have this unique ability to alter our BDNF levels in both directions. So how can we not give a treatment that's like, say, an anti-anxiety treatment to help stop over-exercising, but that might reduce the desire, motivation, urgency to eat sometimes, or without having something that will increase eating behavior, add that sense of urgency, but then also make over-exercise even more extreme. So it's this very nuanced combination of pathways that we are seeing a lot of exciting developments in terms of looking at different ways to address that. Okay, so I briefly mentioned ketamine just now, but I just want to highlight that a little bit more. So what we know in depression is that ketamine is something that's not only used in treatment-resistant depression, but, well, I mean, it is used in treatment-resistant depression, but it's not only useful for its properties for addressing manifestations that might not otherwise be responding to other treatments. But what we've also seen is that it's just very rapid acting. So if we think of traditional antidepressant medications, what we often see is that it can take quite a while for medications to kick in, whereas ketamine has this immediate effect that can be improvement seen hours later or a couple days later, which is really exciting looking at extreme cases. And part of what's exciting in the context of eating disorders is that if we can have this immediate boost, this immediate restoration, it allows for an earlier change in eating behaviors. And if we look at how treatments can always be paired along with talking therapy, whether we're looking at probiotic supplements for the gut or whether we're looking at something like ketamine. What's really exciting about ketamine is that if we can have this rapid acting, this immediate response in what's happening in the brain, by starting to change eating behaviors, it gives a bit more of an opportunity to really launch into the psychotherapy side of things. So one thing that happens with extreme malnourishment is that we're just not going to ever be thinking as clearly when our brain is starved. I know that when it's too close to mealtime and I'm trying to study, it does not go well. So if we can think more clearly, it allows us to approach the therapy in a bit more of a productive way. So there's a lot of debate right now in terms of what exactly ketamine is doing, because it's doing a number of things, but it is thought to immediately boost those BDNF levels, which allows like a very rapid boost in neuroplasticity. So suddenly, very rapidly, we're able to start shifting these circuits a bit, looking back at reward processing, looking back at motivation. We're able to start looking at situations a bit differently, start approaching eating situations a bit differently, starting to understand how, or starting to really see a bit more of a connection between eating behaviors and physical symptoms, and maybe approach those with a new perspective. Here, I've just got a little diagram of how we can think of rewiring these rigid thought patterns, so thinking of cognitive flexibility, as we start to think about changing some of the fixed patterns and behaviors. What's really most helpful is thinking about how this diagram might help to visualize some of the circuits that we've just been looking at. So just to draw your attention to a few of the areas, I know I was very broadly speaking about reward processing, about cognitive flexibility, about emotion regulation, but on a bit more of a detailed level, we might see certain things where our rewards or our flexibility might be impacted by things like understanding prediction error or predictions. So I explained it a little bit in terms of the reward processing for if we're hungry, we eat, we're satisfied, there's this desire for the reward, then the satisfaction with the reward. But what happens with prediction, it's looking at a cognitive neuroscience side of what do we expect is going to happen. So what might we expect from eating, or what might we expect when we think about something like weight gain and how that plays in with eating. So the prediction of if I eat, X will happen, which can often be disrupted in eating disorders where we get these extreme fears about what will happen with eating or what could happen if there's weight gain. So if we go back just looking at memory for a bit, so we looked at our flexibility, our memory, our motivation. What we're seeing is that we have these prediction errors that can come in where we might be associating a possible outcome with past experience or expecting something to happen, which is then going to influence our behavior moving forward, how willing we are to change our behavior, which then we have the updating of behavior and that idea of getting stuck in a particular way or stuck in a particular pattern. And the reason that I wanted to bring up prediction errors, one possible tool that is a non-pharmacological behavioral intervention is a lot of research looking at how we can use virtual reality for treatment of eating disorders. So for anyone who has never looked at virtual reality in the context of mental health, which might be all of you, I don't know. It's quite a new thing. We might think of virtual reality as like video games or arcades. I know what Battersea Power Station, they have one of those VR arcades, or thinking of the metaverse. But VR is becoming increasingly popular as a tool for treating psychiatric disorders. We've got like a whole range. It's particularly popular at the moment when looking at psychosis, when looking at PTSD. It's being explored a bit more in some disorders than others. So the image on the left here is graphic from a VR trial that was done at the Institute of Psychiatry, Psychology, Neuroscience at KCL, exploring VR as a possible tool to explore fears in eating disorders. So if anyone knows what exposure therapy is something that's often used in phobias. So if we think of a fear of doing a certain thing, so like a social phobia or a social anxiety, perhaps exposure therapy would look at an incremental exposure to social situations, or a fear of heights and flying. How can we gradually expose to that fear, to overcome it? So it links back to Pavlov's dogs and conditioning. And if we hear the bell and expect the food reward, like the dog, hearing the bell again, the reward will continue to be expected. And that can happen in a negative way too, where we might expect a bad outcome. So what VR gives an opportunity to do is to start to explore certain fears around eating, around weight gain, around expectations of what might happen with food, but in a controlled environment. So this is a possible way of treating eating disorders. But of course, we also do have real world food exposures that are happening simultaneously. But what this particular study here looked at was, you might see in the bottom left-hand corner here, we have a little pink elephant, the elephant in the room, which shows that a way that was tested of looking at fear foods was understanding how different environments might actually help recondition associations with specific fears, for example, specific fear foods. So in this particular trial, the participants were split into different groups where the task was to pick up and serve this virtual cookie. And the environments were to do this task either alone in the kitchen with a pet, which was a pink elephant, or in the kitchen with another person. The pink elephant is something that was chosen by the participants. The study was designed in collaboration with lived experience perspectives. So that was a very intentional choice. In case you're wondering why the pet's a pink elephant. But really the key finding here was just that fear levels reduced a lot in a very safe environment, including exposure to the virtual pet before the food exposure and during the food exposure. So if we think of how that might translate to looking at eating disorder treatment, there's the idea of looking at exposure to food and how we can change behavior by creating new positive memories with food. And what this is really stressing is the need for positive memories. So often eating disorder treatment programs can involve just refeeding as a really big part of the treatment. But when we've got perhaps more negative experiences that are happening during that exposure, it might not be helping to change certain associations or certain ways that individuals might experience fears or thoughts around eating environments. Okay, I thought I was going to mention one more, but I did not put a photo. I thought I did, which was just another type of exposure being looking at a virtual representation of one's own body at different body weights, which is a way of doing an early exposure to accepting what different changes in the body might feel like and how we can start to maybe gradually shift thinking around physical changes and make weight gain or changes in the body feel a bit less fearful by having that limited safe exposure. So looking back at everything we've covered today, we've kind of gone through a number of different possible treatments looking at anorexia, both in terms of physical manifestations, psychological manifestations, gut-brain axis, BDNF, then looking at sodium treatment in VR. These are both possible tools that might be useful as an adjunct to talk therapy or group therapy and refeeding. I know that's a lot of information, so I will leave it at that, but I would love to hear any questions anyone might have or any comments that that people might have on this content. I know I've thrown a lot at you, so.
Hey Margaux, that was brilliant. I've got some questions in the chat. Satish, if you're here, perhaps you want to ask your question direct.
Thank you. That was a very insightful presentation. As I was looking at the diagram of the BDNF factors, I noticed there was no insular cortex in that diagram. So I was wondering if any atypical BDNF levels were observed related to anorexia, given that insula is one of the central hubs of integrating the interoceptive signals, especially including the vagus nerve. It also has been studied quite a lot in terms of eating disorders. So I was wondering if BDNF had any observations within insula itself. Thank you.
Thank you for asking that, because I think it's really interesting that you mentioned interoception, because there is a lot of evidence linking impaired interoception to anorexia and to eating disorders. So if anyone doesn't know what that is, it's the ability to sense what's happening in our bodies and be aware of emotions, but also aware of physical cues like hunger or pain or whatever it might be. So I'm not actually entirely sure about BDNF in the insular cortex, but it's definitely something that I now want to look into, because thinking about implications in anorexia, I feel like would be really useful to know how that might play out. I think part of the challenge is that a lot of the more detailed understanding that we're getting is related to animal models specifically. So I think as we continue to advance ways of measuring levels in specific regions and circuits within humans, that might help us to get an even more accurate snapshot there.
Yeah, that makes sense. Thank you. Yeah, I mean, I was reading something. I don't know if you've come across this paper. I can reference it by Bud Craig, which actually puts insula as one of the hubs of the sense of self, which is like interesting because anorexia has a very important implications in anxiety, right?
Mm-hmm.
And the sense of self and interception are all getting processed in the same region. I'll try to put one reference article there in the chat that I thought was interesting. Thank you.
Brilliant. Thank you for sharing that.
Sure, of course.
Did we have any other questions in the
We
chat
do.
that
We do. We've got another question from Lena. If you're here, Lena, do you want to ask and provide some context?
I was just wondering about the environment. Is it kind of hostile environment, like a private life, or is it more loving environment?
Yeah, with environment, are you referring to sort of exposure therapy environment?
No, private environment, like home situation. Because there is a talk I've been listening or watching in the past 3-4 weeks. I do not know whether it is correct or not. So the flight and fight instinct is only for male, but not for females. Females would rather go to a tribe or to friends and connect with friends and to protect the body or to protect yourself. So fight and flight is more male instincts. Does it make sense?
Yes.
But I don't know what the author was referring to who gave the talk, to what papers. But from that idea, if it is a female and she does not have a loving environment, it could be that environment is creating the eating disorders.
I see what you mean.
But it's obviously really complex phenomena.
Totally. I think you've really touched on here something that's such a big challenge, because if we look at trying to understand onset, it's like so many complex disorders and like so many psychiatric disorders, we've got this multifactorial interplay of different influences we can have. So there's a certain body of research looking at genetic links. We might be predisposed to eating disorders based on our genes, but then there's also another side looking at experiences and lived experiences and understanding traumas or home environments, or which I guess can be general environment or a specific traumatic experience that might shape either thoughts or behaviors. And then we've got the side of like looking at the gut microbiome and those changes. And so we've got interactions in life and then experiences, environments, genes. And so part of what makes treatment so challenging is because an eating disorder can arise for so many different reasons, and there might be a really complicated interplay of different influences. How do we know exactly what to target? Because I think there's probably a large portion of people who have environmental influences, and then others who might not feel that their environment really did have as much of an influence in terms of looking at home environment or immediate environment. So yeah, always complicated.
Thank you.
I've got two more questions. There's one from Hema. Would you like to ask direct?
Hello, Teresia. Hi, Margaux. Thank you so much. That was really great, really interesting talk. I had a question about the ketamine-assisted therapy that you mentioned for anorexia. Do you know if the research suggests that the intervention is going to work best as a structured course of treatment to support this recovery, or followed by top-up sessions, or is it more of a one-time intervention with lasting effects?
So I know I did stress it as a big possible avenue, but it's definitely in early stages. All of the trials really that have been done to date have been using ketamine in animal models, but the first application in humans, the study is underway. I don't know if administration has started yet, but definitely recruitment and the whole process has started. And it's, again, coming out of King's, looking at ketamine. And that is for multiple ketamine administrations. So the plan for this preliminary trial in humans coming out of King's is to have the first few interventions happen monitored at King's, and then actually have subsequent doses that are taken at home with regular follow-up. So it is sort of a more regular course, not a one-time treatment. But I was thinking about all of this during your wonderful talk yesterday, how psychedelics might be a really interesting option for shifting that new perspective, because you talked about was looking at things anew or looking at things differently with psychedelics. So it could be just a broader exploration in eating disorders.
Yeah, you know what, Margaux, that's exactly what I was thinking throughout your talk and you explaining the ins and outs, especially the behavioral side, which I'm really interested in exploring more of. And same as you suggesting, I think psychedelics is definitely an avenue to explore, especially behind the thought processes of what you described these individuals are going through, helping them shift perspectives. But genuinely, thank you so much.
I'm sure we'll keep chatting. I'm sure the conversation will keep going.
There's a question from Lucy. Lucy is asking, is earlier intervention of even more importance in anorexia as fasting and exercise could at least initially increase BDNF levels and support maladaptive neuroplasticity? She's thinking of her own past experience in which she associated eating with pain and was rewarded with less pain by not eating and found that quickly spiraled.
I think the early intervention versus persistent eating disorder topic is a huge topic of debate in eating disorders because there's limited funding. Quite honestly, often with early intervention, part of the reason that outcomes are so much better is just that by catching it early, it's before things get as disrupted or before circuits are as fixed in a certain way or before BDNF levels might be as skewed as we might later see, or even differences in the gut microbiome. Like we have disruptions that continue to just get more disrupted over time. So early intervention is like this great way to try and catch things before they become as severe, not only in terms of eating patterns and behaviors, not only in terms of weight loss, but in terms of overall changes that are happening both psychiatrically and physiologically. But then at the same time, I guess the other side of the debate is looking at things like high mortality rate and people who are having repeated courses of treatment or individuals who might be not getting better in treatment. And both are really urgent. And I think perhaps the way of looking at that debate is not looking at which one is more important to study, but how we can effectively address both early intervention and more persistent or chronic manifestations effectively without either one being overly compromised. But it is really exciting looking at developments in early intervention and how we can try to find ways of avoiding a crisis getting to be as much of a crisis before it gets there.
That was the last of the questions. I'm not sure if anyone left here just now have any more questions. I had a thought that popped in as you were speaking about past, if you like, and current, and how much things have moved forward with the research as far as stigma. And there are conversations where you discuss the biological, the hereditary, neurodevelopmental factors related to environment. It's so complex, and there's much more understanding now, I hope, for sufferers. Is that a conversation you have often?
Yeah, I think that's something that's really moving things forward in that way, is looking at now our more recent understanding of eating disorders and their global prevalence, as well as understanding that it's not just a female phenomenon. Because I think traditionally eating disorders were often viewed as an extreme diet, often associated with privileged white females, stereotypically, that was the association. But now I have somewhere a graphic saved on my computer that's a map of looking at eating disorder prevalence worldwide. And what we're really seeing is that there's nowhere that's unaffected. And what that is kind of showing us is that it's not really just an extreme diet in terms of Western beauty standards or Western ways of thinking or behaviors, because then in different cultures where there's different views on how we perceive either the body or weight or our own behaviors towards altering our appearance, if we're still seeing a lot of eating disorders there, I think that's what really makes people step back and think, wait a minute, how can we understand this differently? Just like as we start to see more men that might be expressing challenges who may not otherwise have been voicing it because of stigma, we're starting to think, okay, this might not just be a very extreme sense of vanity. There's something else that's happening, and we need to look at this a bit differently. So I think it's a hugely important conversation. It's still happening. There's still right now a lot of issues. There's a BBC documentary that recently came out about stigma in terms of how eating disorder sufferers are treated in NHS treatment. And it's a bit of a tough watch. But there can still always be stigma and treatment. But I think that slowly but surely perspectives are changing. So, yeah.
Yeah, thank you. I've got one more question here in the chat. Hi, Netta.
If I can say something?
Yeah, please do.
Ahead. Yeah, so thank you so much, Margaux. That was really informative in terms of neurobiology and all this research from neuroscience. Absolutely wonderful. I love it. My question is, what have you been seeing in terms of research on emotional side of treatment, because you have mentioned a few times, and I completely agree that it's also emotion dysregulation disorder, if you like. So what is done? So we know that we're looking at physiological manifestations and the brain manifestations, trying to target things with the traditional CBT, thinking that if you change thinking, then it will go away or it will help. And so I certainly agree with most of this. But I think which is hugely missing for me and for people who talk about it is this emotional component that from psychotherapies that it is necessary in a treatment, and it does make a change to move forward. When this is removed, things do not really go forward. So I don't know if there is research about therapies that address emotional dysregulation. So that's my question. And just one more clarification. You said that there is virtual reality implemented already in therapy. I would love to know where, because as far as I know, it's just been researched. It's only been researched, and it's very difficult to see a place that has taken it to the patients.
In eating disorders, it's still very much just in research populations. It's not anything that has translated into practice. I think some of the most recent developments in VR are not necessarily in clinical practice just yet, but I think some earlier iterations, particularly looking at phobias, are in practice, but I couldn't say exactly where. I might be able to follow up with that information. Not sure clinic where that might be available. Also, to answer your thought about the emotional side of things, I was actually just going to try to pull up a graphic that I have, but I will start talking as I check for it. I do think that the emotional side of things is so incredibly important in eating disorders, and often what we can end up seeing in inpatient settings is that when body weight does get particularly low, there can be this preference to treat only from a physical standpoint without treating the emotional side of things, because the idea is that individuals require physical stability first and then treating the emotions. But I think that's a really challenging way to go about treating eating disorders, because often the emotional side is actually a key maintaining factor. Like, it is the eating behavior, but it's also what is causing the disordered eating behaviors, or what is maintaining disordered eating behaviors. And okay, so this is a graphic. What I love here is I mapped this out because I just find it fascinating looking at the various different manifestations of eating disorders. So in blue, all of this is behaviors. So that's, again, what's often treated in terms of trying to change eating behaviors, exercise behaviors, purging behaviors, and to prevent these unwanted physical outcomes, which are very scary too. You know, there's this possibility of what can be very severe outcomes. But then all of this purple stuff are the manifestations of eating disorders that are not physical at all. And that's a huge part of eating disorders. If we look at the large 3 circles, these are the diagnostic criteria in the DSM-5. So 2 of 3 of them are not even physical. 2 of 3 of them are related to, okay, one is perception of one's own body, but intense fear of weight gain. That's already covering the emotional side right away in the diagnostic criteria, and knowing that anxiety is something that can lead to restricted eating. It's something that might arise from distorted body image, but it's very much an emotional response. I have various different iterations of this. Clearly, it's just a little passion project of mine. But in terms of the behavioral side of things, I think it's really, really challenging to try and shift a behavior when the emotional side is not being addressed, because we can keep trying to change eating behaviors, but when the anxiety is there, when the intense fear is there, when low mood is there, impacting motivation, it's hard to shift a behavior because it's really those emotions that are maintaining the behavior. So I personally am a strong believer that talk therapy is addressing the emotional side of things is always necessary, regardless of treatment stage or what other treatment is being done. But I think that it's something that definitely varies from treatment environment to treatment environment. And I know it's already very different between Canada, the States, the UK. Those are some environments I'm a bit more familiar with, which are all very Western specific environments. And I'd be curious to see different environments. Yeah, there's a range depending on the treatment environment, but it's something that I think we really need to think about prioritizing. So I hope that helps.
I think that's proved beautifully, because I was missing this element and I really wanted to know what you think about it. And as you said, it's not properly addressed in the research and we don't have much, but it's wonderful that you see this and propagate for being it as a part of treatment. Thank you, Margaux.
Thank you. It's so exciting to see everyone who was interested in talking about eating disorders today and all of the interesting conversation that's happening. I think it's really promising for future developments and changes. So yeah, thank you to everyone for engaging in this conversation today and coming along.
And thank you to you, Margaux, for presenting today and for leading our SIG. I'm really excited about what's to come.
Absolutely. And I look forward to the talks in the next couple of days.
Thank you so much. Bye, everyone.